am just really delighted to be here with our team and just a wonderful group of Washingtonians who have been focused on updating the district's health systems plan. So I want to acknowledge our leaders in our health and human services space. Let me start with Dr. LaQuandra Nesbitt, who is the district's Director of Health, as well as HyeSook Chung, who is the Deputy Mayor for Health and Human Services for the district, and Robert Brandon, who is here, who chairs this committee, correct? Thank you. And I'm told that we have one of the most robust updates, which is required every 5 years since 1989. So let's give the entire committee a big hand for their part in that. So the district State Health Planning and Development Agency is part of the Department of Health, and it is responsible for developing a comprehensive health systems plan. And that's what we're here to talk about today. I repeat often that we want to make sure that every resident, regardless of where they live, regardless of the resources their family has, can in the District of Columbia have access to the best medical services possible. And we know that the investments we make in our city and our residents should contribute to wellness, health and wellness, and just the well-being that we expect in our city. It is one thing to say that 99% of our people are insured. It's another thing to say that they go to the doctor. It's one thing to say that we have primary care and we have invested in it and made it significantly more robust. It is another thing entirely to say people are using it. It's one thing to say that we've added ambulances so that we can decrease wait times and everybody has access to emergency care when they need it. It's another thing to say that people are actually using it appropriately. So when we can say yes to all of those things and many more, we know that we have a health system that is working for DC residents. There are 3 big goals of this plan, and I'm going to talk about them at a very high level, and Dr. Nesbitt, of course, will talk to you a little bit more. First and foremost, we want to make sure that it's easy for residents to understand and make it easier because of our planning for residents to access care near their homes. We want to ensure that we are coordinating care more efficiently and effectively. And we know that we have to work together to fill gaps in care, especially when it comes to specialty care. We really want to better understand the gaps in service and barriers to access all across our city. We need a better grasp of how things like income and education level and transportation and employment and public safety, housing, drive our overall health outcomes in the nation's capital. We've conducted extensive research on the ways residents are getting care. We sought community input on what residents want to see in their healthcare providers and services. And many community leaders and healthcare advocates and members of the healthcare industry helped us monitor and evaluate our data and develop this plan, which we think is forward-thinking and is going to very well serve our city over the next several years. Let me say a bit about the key takeaways. We want to ensure that facilities are used in the way that they are designed to be used. And even though healthcare resources are now spread across all 8 wards, residents continue to travel across town in many cases for specialty care. We want that to eventually be the exception and not the norm. Studies show that when people know that they can see a doctor nearby, they are less likely to make unnecessary emergency room visits or 911 calls. So part of this plan mandates that we get the word out about health services, particularly specialty care options, available to residents right in their own neighborhoods. So we are going to talk a little bit more. I'm going to ask Dr. Nesbitt to talk a little bit more about the recommendations included in this report, and then we will be prepared to answer any questions and, of course, hear from Mr. Brandon. Dr. Nesbitt.
Thank you, Mayor Bowser. I want to thank Mayor Bowser for her continued support here in the District of Columbia. It's always a pleasure to serve for a mayor who absolutely gets health and recognizes that we don't just celebrate that our residents have some of the best insurance coverage and access to health care in the District of Columbia, but we have to always remain focused on whether or not that access to care and that insurance coverage is going to lead us to be the healthiest city in America, which is our charge here, not only at the Department of Health, but also with all of our sister agencies who have a responsibility to help us get there as well. As the mayor mentioned, the District of Columbia is full of a number of health resources and health assets that would be considered world-class when compared with any other jurisdiction. The purpose here of our health systems plan is to make sure that we have a guidepost or a roadmap that keeps us focused on continuing to build that robust health system so that we have equitable access to affordable, high-quality health care for all of the district's residents, regardless of place, regardless of their socioeconomic status, or regardless of where they live in the District of Columbia. I'd like to thank many of the people who have participated in the plan and who have been supporters of us and who have given us constant feedback. Some of them are here with us today. We have Tamara Smith, who is the president and CEO of the DC Primary Care Association, Jacqueline Bowens, who is the executive director of the DC Hospital Association, Karen Dell, the market president for AmeriHealth Caritas DC. We also have with us today Eric Wolcott, who from the DC Home Health Association, and Dr. Julian Craig, who has joined us from MSDC. We also have with us one of the sister agencies who helps us in our journey toward being the healthiest city in America, and that's the executive director of the DC Office on Aging. Some of the key findings that we have from the plan, as mentioned before, is that DC is rich in health services and facilities, which are well distributed across the District of Columbia. That includes primary care assets, which we have invested in over a 10-year period of time, over $75 million in healthcare assets. We are the envy of many of our friends, and we even had one of the physicians who spoke on behalf of some of the private docs talk about how some of our federally qualified health centers become the envy of some of the private docs in our community because of how state-of-the-art, new and up-to-date and modern these healthcare facilities are in the District of Columbia. We have some gaps and barriers that continue to exist as it relates to specialty care. These specialty care gaps often require some of our residents to travel distances in the District of Columbia that lead them to cite transportation as a barrier to their health care. It's important for us to emphasize that this barrier to health care is not a barrier to primary care, which seems to be the entry point for many people into health care as we think about navigating the healthcare system. Even many people start with a primary care physician or a nurse practitioner or physician assistant, helping them to begin to understand their health needs, both from a preventive health perspective and healthcare maintenance for people who have chronic conditions, but their need for specialty care often requires them to travel distances. We recognize broadly across the District of Columbia the role that social determinants of health play in us being able to achieve those population health goals that we've set for the District of Columbia. Many of those goals are outlined in DC Healthy People 2020, a plan that we use to really inform this health systems plan. And that plan tells us the goals that we want to have for ourselves as a city by the year 2020. So where do we see ourselves as it relates to our asthma rates, our diabetes rates, what percentage of our population we want to have screened for those preventive types of cancer. We recognize the role that social determinants of health like education and income and employment play in our ability to achieve those goals. The next thing that one of the key recommendations from the plan is that a high percentage of our residents are utilizing emergency room and emergency department services or calling upon our 911 system for healthcare conditions or health problems that are better served in the primary care setting. We recognize that this is a mismatch for us because many of our residents have insurance. Many of our residents are living very close to a primary care facility and have access to a place where they can have those needs met, which is a far more appropriate healthcare setting than using the 911 system or going to an emergency department. This is appropriate. This is of a huge area of concern for us because when you use the 911 system for a non-emergency, it prevents us from being able to respond to an emergency and can delay the treatment of care for someone who actually has an emergency in the District of Columbia. So we really want to get our residents to get the right care at the right time in the right place. One of the last key recommendations that I would like to emphasize is the need for better integration of care. So what do we mean when we say the better integration of care? Many of us wake up in the morning and we want to be treated like a whole person. We want our entire selves to be taken care of everywhere that we go. We don't want people to separate out one part of us when we have interactions. That's how we should think about people in the healthcare environment. So when people have behavioral health needs and physical health needs, we should do a much better job of integrating their health care. The same thing happens when people are discharged from a hospital setting. We should make sure that they have as seamless of a time getting the health care services that they need when they return to home, as it relates to home health services or long-term care and supports. So integrating that care, coordinating that care is one of the next steps that we need to take in the District of Columbia to improve health outcomes for our residents. So some of the key recommendations, I've also already begun to highlight some of them as I gave you a highlight of the key findings, is that we really should promote better engagement as it relates to quality and timely primary care and behavioral health services for our residents and reduce barriers to care. We should do this by prioritizing the elimination of those barriers, such as it relates to transportation. A great example of this would be to begin to think about how we strategically place specialty care in those neighborhoods where we have residents who are telling us they're traveling distances to get specialty care. This would improve quality of life for our residents to be able to have specialty care in their own neighborhoods. We should really work aggressively and strategically to develop collaborations and cooperation among service providers who provide all of these, what we call building blocks of an integrated health system, so that primary care and behavioral health and inpatient care providers are all working collaboratively with each other to understand what the whole person needs, and also doing this in partnership with our home health agencies and long-term care service providers, treating the whole person and also recognizing, more importantly, what their social support needs are as a means for us to be able to achieve health equity. And then the last key recommendation that we have is thinking very strategically about how many of our health systems who have a responsibility for conducting a community health needs assessment and investing in community benefit, use that community benefit to help advance the goals of the plan. At this stage, we're really having discussions about the plan for all of those key stakeholders and key players in our health system so that we begin to have alignment. But the plan really can't be implemented successfully in our community, and we can't advance the goal of being a healthiest city in America if we don't translate this language into something very meaningful for each one of our residents. And so it's critically important for all of us to take the next steps into being able to speak with one voice and communicate with every resident that we come into contact with wherever they interact with our healthcare system. So thank you, Madam Mayor.
Thank you, Doc. Thank you. I got distracted towards the end of the doctor's remarks because I was thinking about going to the hairdresser, having my makeup done, eyebrows done, and a massage. Is that what you mean by integrated care?
That's what I mean by integrated care.
I'm all for it. But you're right. I want to have all of those things done all at the same time. And I think that people also want to be able to get their flu shot, their mammogram, get an x-ray or blood drawn if they need it. And just think if we can capture that close to where they live, we may have a bigger chance of helping them manage any chronic issues and find out early about any acute issues. So now let me introduce Robert Brandon, who is the chairman of the Statewide Health Coordinating Council. Mr. Brandon.
Thank you, Madam Mayor. And I want to thank you for your leadership, and particularly with Dr. Nesbitt. The Statewide Health the staff of the SHPTA that are here today. The Statewide Health Coordinating Council has two main roles. We provide public input and provider input into planning for the city in terms of health planning. And we make decisions about input into certificate of need applications, which are investments in health services for the city. Two crucial areas. I'm very happy to be here because I've been on the council for over 10 years now, and this is the first health systems plan that I believe is really comprehensive and one that can provide an excellent roadmap for the city going forward, and not just for the health department, but for all the residents of the city and all the components of the health system. It's an overarching plan, and it's not meant to duplicate the good work that's being done by agencies now in planning, but it's a long-term plan. And it's a very important product because it can be used by the administration, by the health department, by the various agencies in the city, by the city council, by the providers in the city, by the nonprofit sector, and by the community to sort of understand what's missing in our health system. As Dr. Nesbitt mentioned and the mayor mentioned, we've been blessed with high levels of insurance. That's the commitment that the city has made a number of years ago, and increasingly good access to primary care around the city. But we have a real problem in terms of the proper utilization, as mentioned, and frankly, just reaching lots of elements of the community that just won't go see somebody when they're sick. So it's going to be very important to use this plan in that regard. The HyeSook helped shape and guide the process. We represent the public and the providers, as I mentioned, with input from DOH and from the SHPTA staff. And it's important to make this plan relevant to all aspects of the city. And it was touched on before. That means that our school system, our transportation system, our parks and rec system, the community groups, the nonprofit community, all have to understand to have a major role to play in increasing the public health outcomes and creating a more healthy city. We had three main goals when we started this process. One was to gather the best data available, and I think we put the department hired some very good consultants. They worked very hard to get excellent data, and this is the most comprehensive set of data that I think we've had in terms of utilization, in terms of hospital use, in terms of where people go to get their care in the city. And also we wanted to cover all aspects of healthcare delivery. So that's looking at what the capacity is, particularly with primary care and also with our other provider capacity and utilization. It also meant to really document the public health challenges that the city faces and that the community faces in terms of chronic diseases and other areas that create barriers to health care. We looked carefully at the social determinants of health, the different elements of income and race and other aspects that clearly have an impact on the level of health care for residents in the city. And we wanted to make sure there was community input so that when we could identify areas of investment and areas of outreach and education, they were the result of getting a lot of good information from people that live in the various communities that are affected, and not just the providers. We had community meetings in 3 different wards, and we interviewed lots of individuals and activists around the city to get that kind of input. So really, in the end, this becomes a roadmap for making the healthcare system better and improve the health of all of our residents. And it's there are medium goals here and long-term goals. So it's really a living document. I think it's something that we can all begin to look at and take advantage of and guide our policy and guide not just the health department's policy, but the city overall. So I'm very happy to see the result of the plan and look forward to working with everybody in implementing it. Thank you.
Thank you, Mr. Brandon. Okay, so we will take a few questions on topic first, and then I'm available for broader questions. Yes.
Tina Reed from the Washington Business Journal. I just wanted to better understand what makes this different from other reports that are out there. A lot of this content I've spoken about with Dr. Nesbitt before about the social determinants of health. So how is this different from what's already out there, like Healthy People 2020? What is the tangible impact
Sure. I think that the most direct way to answer you is this directly informs the Department of Health's and the committee's consideration of certificates of need. Would you say that's um, the most specific purpose of the report is to help inform that process? But you're right, it does build on a lot of work that we have done. And the Healthy People DC continues to be set out many goals for us to follow. And I think what is contained here in this report is a roadmap to get there specifically. Dr. Nesbitt, would you like to add anything?
So just to reemphasize the mayor's point, this plan has more to do with integrating some of the elements that we've already released. The other ones have more specific around health indicators. This one is more of an alignment of a health strategy that encompasses how we invest in our infrastructure, how we pull together some of the elements that are related to policy. But this one can also be used as it relates to making decisions through the certificate of need proposal process, where people are looking to make new capital investments or add lines of service as it relates to healthcare in the district.
Other questions?
Yes, ma'am. Hi, I'm Laura Kelly from the Washington Times. Talking about the emergency departments and too many people using them not for the right services, what kind of solutions are you looking into? Are you looking into other places where people who call 911 can be transferred, such as people who are suffering an opioid overdose can go somewhere else, or people who have behavioral
this is what we're talking about. And let me tell you about some things that we've already done. So you know what the problem is, and Dr. Nesbitt will remember better than I do the actual numbers. But the majority of calls to 911, what we found, are not cases once our fire and EMS department get there that require an ambulance or an emergency room visit. So what we have really spent the last year doing is trying to figure out how we can better align our residents to the proper services, right service at the right time in the right place. We have, for example, in talking to our Medicaid providers, and in the last contract that we put out to work with them, asked them to help us come up with ways to ensure that our insureds, our Medicaid insureds, are using the proper service and using the transportation services that their insurance already provides. Last budget season, we put in our budget a pilot program, and it's called a nurse triage program. We will actually be putting out a request for proposals, and we're seeking a partner so that we can embed a nurse at the 911 call center. And that nurse will be able to help triage their complaint, their call, to see if they need to go directly to the hospital. An ambulance will be dispatched. If, however, they can be, we can work with their Medicaid providers for transportation services, or recommend another provider, another transportation provider to them to get to the hospital if that's what's needed. So that pilot program, we have great hopes for it. The council agreed with us, and I think we have $1 million program that we hope to be ready in the early part of next year. There's also a public education component, because we can put all of those things in place, but if people don't know about them and all they know is 911, we're still going to have overuse. So the basic, when I became mayor, I don't think we had added any new call takers at the 911 call center in 8 years, and we hadn't really added any new ambulances in a significant way in almost the same period of time. We are now handling low priority calls with a third-party provider, and that just demonstrates, just by definition, those calls are low priority and probably could be handled by another transportation provider and probably don't need to go to the emergency room. So we're getting just a full and complete picture of how this can work. And what that means is, for the person who is suffering an emergency, they can probably get faster ambulance service and probably faster service once they get to the emergency room. And what that means for the person who is not going to the ER is they're probably being connected with their primary care doctor, who can examine them for a plethora of medical concerns. Yes?
In that same vein, I was actually reading I'm sorry, I'm Colby with the Washington Post. Colby Erkowitz. I was reading Mayor Fenty's health plan from 2007, and there's a whole section on health disparities. I read somewhat similarly, so that means in 10 years, we're facing the same problems when it comes to health disparities. So I'm wondering, what your plan is so that 10 years from now,
We were around back then. I don't think 10 years ago the story about primary care access would be the same. It may be, we may still have a gap in specialty care, but that may even be less acute. So let me ask Dr. Nesbitt to talk about some of the differences since 2010. But your point is well taken. These are stubborn issues, but we have made significant I may also ask the Primary Care Association if they want to remark on this a little bit. Dr. Nesbitt?
Thank you, Madam Mayor. So I returned to the district in 2015, and as the mayor mentioned, I had spent some time in the district prior to that. One of the things that I will say that are critical differences is that the district as a whole has become healthier since the time of the release of that report, but we have persistent gaps that remain in health status between certain population groups. One of the reasons why we took the approach that we did with this particular plan is that we can't continue to rely on the fact that we have high rates of insurance coverage and that we have a number of things such as inpatient hospital beds or that we have only invested in the capital infrastructure for primary care, so to speak, and think that that will give us cover for eliminating health disparities. We have to double down on our efforts as it relates to working collaboratively with our primary care providers to understand what their challenges might be as it relates to workforce in terms of recruiting and retaining healthcare providers. The initiatives that have been kicked off under Mayor Bowser's leadership that focus on getting people into the healthcare environment, focusing on prevention and wellness so that people stay healthy as long as possible, and those types of efforts, which were not as prevalent 10 years ago, are going to be the types of things that move the needle in a sustained way that can last in our community. We have a number of partners who are collaborating with us in a way that was not seen 10 years ago, and those are the types of things that have to happen. What I will say, too, is that health conditions and health challenges can be stubborn in any community, whether you're looking at the District of Columbia, any other state, or the nation as a whole. So the initiatives that we're talking about today, you should begin to see progress on those 10 years from now, not tomorrow. So we want to manage expectations, but what you should be able to do is measure our progress in terms of how we work together and be able to hold us accountable to the commitments that we're making today to do a much better job of that.
Okay, anything else on topic? Yes.
I wanted to ask about what this means for hospitals and their uncompensated care and how they spend it. I believe you touched on that, and I want to see, should this have any sort of impact on their community benefit spending, or and is it binding at all, or are there incentives that are tied to it?
So at this point, that's just a recommendation that we have here. We haven't made any definitive decisions in that specific area, but it's one of the things that we'll be looking forward to exploring with all of our key partners.
And I would just say quickly, the HyeSook is focused on this fairly substantially, and we want to make sure that the benefits are decided primarily by the needs of the community and not by the providers themselves.
Okay, off topic. I know you have a Matt.
I have a quick question. We're back in session upstairs. Lawmakers are making yeah. And so one of them that's getting a lot of attention today, and I wanted to ask Dr. Nesbitt too, if you could step up too, is David Grasso is proposing this idea of injection sites. I don't know if you've read up on it yet, but basically those who are fighting opioid addictions, they would be able to come to these sites and be monitored by a medical professional and do their drug and also maybe at the same time get counseling. Some might see this as pretty controversial. I'm wondering, as the mayor of the city, what you're thinking. You probably haven't seen the legislation, but
legislation, but I'm certainly familiar with the practice. And I think what should be clear to all Washingtonians is that the nation is really struggling with an opioid crisis. We have been very focused on it in the district. Our experience is a little bit different it's a lot different than what you hear in a lot of rural communities, for example. We have experienced the uptick in fatalities in the district due to a heroin and mostly fentanyl-laced heroin overdoses in our city. And so we take the approach, because in some of these cases, addiction, and especially in the case of heroin addiction, and people who have been using heroin for long periods of time, changing that behavior is very difficult. Our focus has been on how do we keep people alive who think that they can manage through this, because the situation is this fentanyl. People who have been able to manage their addiction for years and years can't manage fentanyl. And that is why we have seen addictions increase. One thing that, and Dr. Nesbitt will talk more about this, is we have explored, and we have some additional funding through the Department of Behavioral Health to explore medical assisted treatment for opioid addiction. And it's a little different. Many people are familiar with methadone clinics, for example, that people who are addicted to heroin can go to a methadone clinic instead of using heroin. There are new medications that are available that can help people manage through an opioid addiction. And so the Department of Health is exploring medical assisted treatment as it relates to opioid addiction. We also, Dr. Nesbitt has planned, and I think is going soon, to do some research in another city that is using injection treatment centers. And I think you're going to Canada. And we will be able to say a little bit more. We want to look at all of our options, but again, I want to assure DC residents that we have a lot of programs in place to help people, not to forget our naloxone outreach, that we are working with providers across the city who can make sure that users and bystanders, friends and family are trained and have access to naloxone.
That was terribly controversial when it first began, but some will point to the results that it reduced the number of HIV infections.
That is an understatement. Yes. And that's another thing we should mention when talking about 10 years ago and healthy outcomes in the district. Our incidence of HIV infection has substantially increased.
Are you looking at this with open eyes then to see if Dr. Nesbitt returns from her trip and finds that it actually is beneficial? Will you get behind it?
Well, I'm going to turn to Dr. We're always looking for a way to keep DC residents alive. And what we have outlined is a problem. And we have some of our residents who are not going to be able to live if they're like the same types of things that they're doing right now today will kill them if they get fentanyl-laced heroin, period. And so we want to be able to treat residents, also make them aware of all treatments and services that are available.
So I think the mayor has given a very comprehensive overview. I don't know what additional I will add. I will just mention that we have a comprehensive working group, the opioid working group, that meets monthly. It's comprised of multiple government agencies who have a responsibility, both from the public health and public safety perspective, including some federal partners from the FBI and the DEA. We convene monthly to talk about these issues. So we'll have an opportunity to review this comprehensively in that forum. In addition to that, as the mayor mentioned, we have made significant investments looking at a broad spectrum of options to keep our residents alive, looking at buprenorphine as an option in addition to methadone. We will also be convening a small summit of key leaders in this particular area next month to talk about policy options as well. So again, just looking forward for a broad policy menu for residents who are challenged with substance use disorder broadly here in the District of Columbia.
Just one question, Dr. Nesbitt. You're traveling to Canada and currently in this place in Canada, where is it?
Vancouver.
So do they allow the person to use their own drugs as they're looked after by medical officials? Is that how it works there?
Correct.
Okay. And so
and they're called safe consumption sites, is how the public health community refers to them.
Okay. And you want to see how they work?
Correct.
Thank you. Appreciate your time.
Yes, ma'am.
Yes, my name is Robin Tucker. I'm the secretary of the American College of Nurse Midwives, and I'm part of task force with ACOG on the recent hospital closures that are impending. Providence is closing its labor delivery. United Medical Center has been suspended from delivering for 90 days. Washington Hospital Center has closed a lot of their postpartum beds and cutting staff. So my question is, if your plan is going to be addressing any of these shortfalls, and what you see as the responsibility of these agencies towards remedying the situation for these women
Sure.
right now and in the future.
Yes, so certainly the plan does address hospital beds and trends, certainly in medical care. As the doctor was briefing me, one thing that people will find is that we have, and when you compare us to other cities of our size per capita, one of the highest numbers of hospital beds available. We just don't have them everywhere we need them. And so that is a focus of how we move forward. Lines of service certainly are our focus too. Providing high quality care, not just beds, but high quality and effective service to residents is a top concern for the department as well. So I don't know, Dr. and Mr. Brandon, if you want to say anything more about bed availability.
Sure. So our conversations about bed availability has to be broader than the number of beds. But when there's a decision from any particular healthcare facility, we look at what the utilization of those particular beds are. Our SHPTA, which issues the certificate of needs, looks at the number of licensed beds, and then we look at the number of operational beds in the District of Columbia. For obstetrical beds in the District of Columbia, obstetrical and gynecology beds, we're at about 55% capacity across the system. So there's a capacity in the District of Columbia for beds to go out of service. I know that there's been a concern expressed about whether or not women in a particular section of the city would have access to care based on these decisions, and whether or not their particular hospital that they utilize no longer being available to them created a lack of access for them. We have looked at data in their utilization of care for the past 10 years and have found that where they choose to go for health care is still broadly available to them, even with these announced closures. So we'd be more than happy to go into detail by the numbers for people who have an interest in that from a data perspective, but we do want people to be assured that the Department of Health monitors these things very closely, has been in touch with healthcare systems who are impacted by these announcements, and have had conversations with them in terms of their ability to absorb any patients who may be coming to them for deliveries.
All right. Thank you, everybody, and congratulations once again on an excellent plan.